So even though my team made fun of me for using a meme, I still think it's appropriate. In the middle of difficulty lies opportunity. So, you know, this is about transformation. We are in incredibly challenging times, not only as a society, but as a mental health delivery system. In our world right now, we're faced with a lot of challenges. And so some of the things that we'll talk about today, some of that transformation, some of the ideas or the energy that really propelled us here came out of some of the challenges that we've recently faced. You can go to the next slide. And so we'll talk to you today in detail about some of the policies that the state was really forced to change on a much quicker basis than we are usually accustomed to, starting with the COVID crisis and really having to flip over to a system that allowed access in any way that was safe. And so telemental health really came to the forefront. Providers had to quickly position themselves to be able to provide supports in a completely different way than they're used to doing. And folks receiving services had to completely change the way they were interfacing with their providers. We dealt with a lot of challenges for our site-based programs like PROS, or any other place where there was a group of people, because of course with the nature of the pandemic, site-based services became more challenging, or people were not willing to go. And so we really needed to think about ways to tailor interventions to better meet people's needs. And so PROS programs and HCBS providers had to really get creative, and we've learned a lot from them and from folks receiving services already about what is working and what is not, and how things were really discovered in this time that helped us to understand how we can better support people through not just the crisis, but how to better meet their life role goals and support their recovery in new ways. So moving towards 2021, the state is really looking at, first and foremost, access, making sure that people who want a service, who identify that they're interested, are immediately able to access those services. And we've had a lot of historical challenges. Katie will talk to you about that later with HCBS. We think that there's some amazing services in HCBS, including peer support and family support and psychosocial rehabilitation and others. But the challenge was always the steps to get to that. So we're going to talk to you about some changes that we're going to be making at a federal level to better support that. And then also the way that we're thinking about our PROS program and modernizing PROS programs. So as I said, COVID definitely gave us a second look on how to deal with and how to be more flexible. And the PROS providers really, it was most challenging for, because they're primarily a site-based program with groups coming together to access those services and support. So we really had to think about what the future of PROS could look like and how we could continue to offer environments of hope and recovery, but to do so in a way that was different and better support folks with different needs. You can go on to the next one. So with that, we thought it might be helpful to talk to you a little bit about the historical shift from a clinical-based model of mental health services to really how rehab services have moved folks forward effectively in their recoveries, and how we're thinking about those two pieces working together in the future so that we can continue to build the momentum and keep a system of recovery and empowerment. And with that, Liam is going to talk to you a little bit about what was like before PROS, kind of how we got to PROS, and then where we might be going. So Liam, I'm going to turn it over to you.
Thank you, Nicole, and good afternoon, everyone. I'm thrilled to be part of this conference. I wish we could all be in person. I wish you could see me in person, because I'm wearing a great tie that I normally would wear to the conference, where I see many of you and enjoy talking with many of you about how you're doing. And
hey, Liam, you should open your camera. We could see it.
I don't have a camera, Harvey, and I don't have a cute cat either to put up there so that people could see. So sorry.
All right.
Yeah, next time. Yeah, and as Nicole said, we're going to talk a little bit about services of yesterday, where we started with pros, kind of where we are today and moving forward. And as Nicole said, this is about engaging people in a way to help them live their best life. And we've learned a lot through the years, and we're continuing to learn and engage many of you so that we can continue to learn again how to better serve everyone to give them the best chance at recovery. So quickly, before pros, we had a day program model that many of you are familiar with that focused on the treatment of mental health symptoms. And it was services delivered predominantly by medical personnel. Not a lot of meaningful personal outcomes, large group services with little to no personal attention. And I remember a CDT in an organization that I worked where there were 40 or so people all crammed into one group room in a group led by a nurse. And it may have been an effective group, but I find it to be a challenging endeavor that each of those individuals was there and learning about ways to overcome mental health symptoms and live fully in the community and benefiting from whatever that topic was that they were engaged that day. And so that was the beginning of kind of a shift in a different direction, a different length of stay, different focus, of course, that time. And again, this is before pros. And with the implementation of pros came this emphasis and focus on recovery. Recovery is possible, and the belief that people are recovering every day, that people can recover, that people can get jobs and have relationships that are meaningful and purchase a house, move into an apartment, and so on. And have an identity that's important to them that they may not have had an opportunity to pursue in the past. So the pros model integrates rehabilitation and treatment all under one program model. And the services are person-centered. There's opportunities for activities in a pros program that allow people to learn skills and practice skills and also to teach skills, which we'll talk about shortly. In pros, the sky is the limit. What are your goals? What's important to you and why? And what's gotten in the way of you from achieving your goals before? Again, is it a relationship you're interested in, or a job, or a housing related goal, and so on? And the participant is driving his or her recovery plan. So the individualized recovery plan, the IRP in pros, is driven by the participant. It's up to that person to work closely with a practitioner to say, this is important to me. And let's work together to identify what service or services among this menu that's available in pros that can help me achieve my objective and my goals. Smaller group sizes with more of a focus on participant interests. The CRS groups, of course, can't exceed more than 12 participants at a time, and IR is a maximum of 8. So again, it's an opportunity for people to be engaged in ways that relate directly to their own interests and achieving their goals. Psychiatric rehabilitation is a new approach, a new path to achieve independence. Some years ago, this was new to many parts of the state. And again, psychiatric rehabilitation is an approach to restore functioning in the community, to participate fully in the community. In pros, through psychiatric rehabilitation, you address barriers and work toward any goal. Again, what's important to you and why, and how can we help you get there? Learning about and utilizing community resources. What resources are available near you that you can access that can help you develop skills, practice skills to support you as you advance toward your goal achievement? Full community participation. And what does that mean to you? It's like recovery, it's individualized. And that means something different to every person. And participating in the community may mean a job, it may mean a volunteer opportunity. Again, it may mean purchasing a home or moving into a nicer apartment or a different part of town, or using public transportation and so on. It may mean voting. This year, as we focus on social issues, a lot of individuals have learned to advocate for themselves and others who are important to them. And this conference has helped shine some light on that. It's been terrific. Pros is also valued employment as a goal. And as you can see to the right, those are the 4 components that are available in the pros model: the community rehabilitation and support, intensive rehabilitation, clinic treatment is part of the model, and ongoing rehabilitation and support is the supported employment service and component. And in PROS, there's an opportunity for peers to teach and lead others through activities, but there's also an opportunity, and I'll talk a little bit more about this, to be part of the staffing plan, this multidisciplinary staffing plan, again, to help people ensure they have the appropriate tools and resources to live their best life. So in PROS, the role of peers continues to grow from many, many years ago to today. The model allows, again, this mixed staffing plan of professionals and paraprofessionals, which also provides opportunity for peers. And the number of peers hired today, the number of peers employed in PROS programs today has increased significantly since PROS was implemented in 2006. And it's increased significantly just in the past 3 years or so. And the conversation with PROS programs around the talents and skills that peers bring to their programs is so different now than it was many years ago, and it's been terrific. And so many gains have been made because of this increased and ever-growing presence of peers in the PROS model, and it's really made a difference. And again, PROS as a model supports skill development through hands-on learning, this experiential learning and supervision. So peers and participants can be part of that staffing plan and be part of this program structure that affords them training opportunities and supervision and support so that they can grow in a professional role. So we'll talk about what COVID, the impact of COVID on PROS and how PROS quickly scrambled to support individuals, as well as what we've learned as a result of this crisis. So the onset of COVID, like a lot of programs, affected in-person services, and PROS, because it's predominantly an on-site program where services are provided in group and in person and individually, impacted PROS programs significantly. And before COVID, telehealth had really never been implemented in PROS widely. And so we learned quickly about the technological as well as the billing barriers that were quickly discovered. Quite an impact. And so we quickly scrambled to develop some COVID guidance to make sure that programs could focus on participant needs, providing participant support, and flexibility for documentation. That was our priority, of course, making sure everyone had the appropriate support they needed to continue to be healthy in whatever setting they were in, because they couldn't access the PROS program. And then, of course, disaster emergency billing allowed for the flow of revenue to programs to keep them open, to keep their operations continued at a full 100% rate, so that, again, the support was ongoing for participants and their needs. So what's working and how can we move forward? So PROS and telemental health, and as Nicole mentioned earlier, we've learned so much, and we're trying to modernize this model. We're exploring ways to determine what we've learned from this crisis and how we can update the model moving forward, because again, we've learned a great deal. So telemental health, right, programs quickly adapted and secured technology for participants, right? There were phones, they were brought to participants to make sure they had phones in hands, and participants that had limited minutes, they made sure they had access to additional minutes so they could participate remotely and be engaged and communicate with the appropriate staff. Program staff quickly organized supports, including treatment for participants for the short term, and that includes injectables. Some participants came on site at a certain day and time so that they could receive their injectables. Some programs delivered care packages, which included food and other supplies to ensure that participants received the support they could so they could be healthy. Great deal of work was done, again, to make sure that everyone had what they needed so they continued to participate remotely. And again, adaptation to new technology, utilizing a wide variety of resources to hold groups securely. So we went from telephonic check-ins with participants to Zoom groups and Google Meet and other mediums of technology to engage participants so that we could see them face to face. And there's terrific work going on today to ensure participants can continue their great work. Not only are they safe now, they're no longer at risk, the work that they had achieved before COVID toward their goals and objectives can now continue, which is critical. Again, lessons learned. So delivering services remotely works. We've learned a great deal from many successful programs who have shared their best practices, and in turn, we've shared those with other programs throughout the state. Telemental health allows a new flexibility and offers efficiency. It's a different time for staff who could be in their apartment and communicating with a participant across town or another part of the county who might be in his or her own apartment, but still practicing skills, learning skills, and so on. Skills can be learned and practiced through the use of technology. There's terrific examples in the pros community today that we hear about on a regular basis of participants completing job applications remotely and working with staff through a computer screen to ensure that they know how to do so and they're supported through this process. Participant to participant support has continued. So without the recovery-oriented activities that have always been available and on-site in the PROS program, participants are communicating with each other between groups, the scheduled Zoom groups, and they're checking in with each other. There's some closed Facebook groups that are available from program to program to ensure participants are connecting with each other and supporting each other. A lot of leadership opportunities have been developed. Some real successes have been gained as a result of participant resilience and PROS leadership as a result of this crisis. And again, the focus on recovery planning and long-term goals has resumed, which again is important. We want to have participants focus on achieving objectives and goals and living a healthier life and ensuring that they understand that recovery is attainable, achievable, and a possibility for them as long as the resources and tools are there to assist them. And moving forward, and now Nicole will share that message.
Sure. Thanks, Liam. So, and again, I see some good points coming through in the chat. So I'm looking forward to talking to you guys more about this and getting some feedback from you about, as you hear some of the things that we're thinking about. And a lot of you on the call either are familiar with the PROS program because you might operate one, or you may have participated in a PROS program before. So I think we have the right folks on this call to give us some really meaningful feedback. Just to get your wheels turning, what we're thinking about moving forward is a hybrid model. So one of the comments I saw come through is, not everybody has the technology to maybe, use telehealth. And I think it's fair to say that OMH's intention is not to create a completely telehealth system. I think that there's value in face-to-face connection, and we know that, and we actually can see the toll that the pandemic has really taken on folks. And so although some of this is out of necessity, I look forward to a time where we don't have to think so much about that kind of a risk when we do come together face to face. And so I think what we're trying to think about moving forward is, without that kind of looming piece relative to the pandemic, what do we want to see this service delivery system look like? So what we know is that some people do prefer telehealth and some people do prefer to come in person. So that maybe that PROS program serves as a sort of hub where people can come, and maybe that's where they can connect when they need to connect. But if they are, if their preference is to actually have either the staff person at the program come to their home to work on skills or recovery goals, or whether that the person would prefer that they call and they do have more of a telehealth relationship, or that there's some mix of those. We're really looking at that kind of a hybrid model to meet all those different needs and desires. So the other piece is, maybe shifting away, as we did, as Liam described, the movement from day treatment, where really people were going 5 days a week, sometimes 4 or 5 hours a day to these groups. Now we're really talking about you know, how do we improve the program or support the program so that they are able to go off site and to do more individualized services. And that whole concept supports that, the hands-on learning. The fact that you may actually be able to help folks who are working on a goal like managing their money a little better if you can sit down with them at their kitchen table and work on their budget together and talk through that in their own environment. And then, you know, thinking about who is accessing our services. So, you know, we've observed that the peer census is getting younger. About 1/3 of folks accessing PROS, I meant to say PROS, is under 34 years old. And so we need to think about how we can better meet their needs. And we're looking at and working with different folks about emerging technologies like apps. Some people want to use their smartphone to access services differently. And so those are all part of what we're thinking about and what we'd like to hear from you. So before we open it up, I think we're going to move into the focus on HCBS and just give you some ideas and some thoughts about what is happening in that area. And so today we call these services adult behavioral health, home and community based services. And those are services like peer support, family support, CPST, which is community psychiatric support and treatment, psychosocial rehabilitation. And so essentially the services, those services are the same, but there are federal rules and regulations directly attached to HCBS, which have kind of given us some challenges on the access points, where with HCBS you need an independent assessor, you need to complete an assessment to determine your eligibility before you even get to the provider of the service. And so what we heard loud and clear, and Harvey was a great advocate all along the way for this, is that, peer support is not something that should come after you had to jump through a bunch of hoops. That really should be upfront, and that should be something offered to individuals to help engage them and support them from the beginning of the recovery. And we couldn't agree more. And so the kind of technical shift in authority that we're making is really about getting people that direct access to these services. So we're calling that array of services, once that shift is made, community-oriented recovery and empowerment services, or CORE, because we still want to focus on the fact that they would be based on, delivered in the community. There are some opportunities to do groups, but mostly individual, and that they're really about recovery and empowerment at their core, and that's how it will remain. You can go on to the next slide, please. Thank you. And what's important about these services and what makes them different than other services within the system, similar to PROS, it's about rehab and recovery. So the person really helping the individual live a life in their community, get a job if that's what they want to do, have successful relationships, go to school, in many areas of in their life where they might want to work on to better participate in the community, to live life beyond just symptom management. That's really what these services allow for. And we want to have a broad array of services in New York State. We want to allow service types that are different so that people are able to access services in the way that they feel comfortable doing so. These services will continue to be for HARP enrollees, and that HARP is a Medicaid managed care plan. Health and Recovery Plans is the acronym for HARP. And it's really about these additional services that support living, vocational, social skills, and again, promoting hope and recovery to support individuals through their path in recovery. Okay, so with that said, I'm going to have Katie Merrill talk to you a little bit more about what kind of changes we are actually making at the state level to better facilitate access to these services. So Katie, I will let you take it from there.
Thanks, Nicole. Hi, everyone. And thank you, Liam, for my slide. So I've been working on home and community-based services for about 5 years now. And in those 5 years, I have met with so many providers and advocates who have told us all about the barriers to accessing these services. And so I thought it was kind of poignant to remember this slide from last year when we came to this conference and updated everyone. And we had all of these barriers to access that were identified. Things ranging from the independent assessment, or what we call the New York State eligibility assessment, which is still, as you know, a requirement for accessing the current BHH-CBS, to things like there was this the very long menu of services that confused people, both individuals trying to access the services and the care managers trying to connect them to the services. It was very difficult to match the individual to the right or correct service, and that led to issues with timeliness and connecting people with the right providers. So as Nicole mentioned, we're really excited to share that we've now officially applied to transition these services from BHH-CBS to core services. This has been years in the making of working with CMS, of hearing feedback from the community, and we've really incorporated a lot of that feedback into our plans for the transition. So Liam, if you want to go to slide 18. Thank you. So as Nicole mentioned, we're now calling these services, previously we referred to them as adult rehabilitation services, and that's because it refers to the demonstration authority that we want to use under the 1115. That's really legal language that doesn't describe what we're actually trying to do. So community-oriented recovery and empowerment services is the new name. We did receive a lot of feedback from providers during the public comment period saying that they wanted to see a more recovery-oriented, hopeful name. We're very excited to debut this. This transition, we hope, will eliminate many of those barriers that were on that previous slide, while preserving the heart of the services, which is individualized, community-based rehabilitation and support services. We're going to focus on staff development through workforce development, trainings. We're going to look at what's currently available from our training partners and make sure that staff are accessing the right trainings, make sure that people are using evidence-based practices throughout the services. And I really want to emphasize that the intent here is to increase access. We want to minimize disruption for providers and specifically for the members who are currently receiving services. We are going to have a transition period to make sure that people don't lose any services as we make the transition. And we're going to work really closely with providers to make sure that that happens. Next slide, Liam. So here you have what we've proposed to CMS as our service array for core. It's 4 services. This might look familiar to those of you familiar with the PROS model. We have community psychiatric support and treatment, which is the primarily clinical counseling and treatment piece, which occurs typically in people's homes or in community-based locations. We have therapists who are meeting with clients in coffee shops and in libraries, and we want to continue that. We want to make sure that people are able to access that mobile clinical treatment piece, particularly if they haven't fully benefited from site-based clinical treatment. Then we have psychosocial rehabilitation, which is your classic kind of psych rehab service. It's going to include a number of vocational and educational components so that people can truly be supported in their goals, whether it has to do with where they want to live, work, learn, or socialize. And then we'll have family support and training to make sure that families are supported in supporting HEART members. So they're going to receive family psychoeducation. There may be access to family support groups, very similar to the existing family support and training service, but with the removed barriers to access, we're hoping to see a much higher uptake. And lastly, but certainly not least, we have the empowerment services peer support. And as Nicole mentioned, we're really excited to be able to reduce the barriers to access for this. As many of you know, in the OMH system, This is the only way that we're able to pay for a peer support service with Medicaid dollars. That's not to say that we don't have peers working in other programs, but for example, in PROS, they're delivering a PROS service. So this really is about peers delivering intentional peer support. And we're very excited to continue this service under the new core services. Next slide. So this slide is really meant to demonstrate what's happening with psychosocial rehabilitation. I know that that can be confusing, that we're rolling all of these services up under PSR. I think the key thing to keep in mind is that the intervention comes down to things like recovery planning, psychoeducation, skill building, rehab counseling, and these cut across all domains. So whether you are providing a vocational or an educational service, what you're really doing in many cases is rehab counseling or psychosocial rehabilitation. So we're just going to have that one service, PSR. This should simplify things for individuals and care managers and MCOs who are trying to select the right service. If someone has a need for skill building, if they have a need for rehab counseling, then the referral would be for PSR. The new PSR will support people, like I said earlier, with living, working, learning, and socializing, and there's going to be an emphasis on evidence-based practice. So this is where you're going to see things like WRAP, which is Wellness Recovery Action Planning. You're going to see wellness self-management, cognitive remediation, and of course, individual placement and support and evidence-based supported employment. And we want to make sure that we're paying for as much of the evidence-based model as we can with Medicaid dollars. As many of you know, there are some limits to what we can do with supported employment under Medicaid funding. But we do believe that this service is going to be able to support people with the skill building and with this, with the rehab counseling that they need to be successful in any environment. Next slide. So crisis respite, right now under BHH CBS, we have short-term crisis respite and we have intensive crisis respite. Intensive crisis respite, I believe there's only one or two that's currently operating in the state, and that's the residential crisis model that's staffed with nursing and medical staff. We have many more short-term crisis respites, which are staffed with peer specialists. These services are going to be transitioning under the 1115 to the mainstream managed care benefit, which means that they'll be opened up beyond the HARP. So right now, under BHH CBS, you have to be a HARP member. Right up front, we were able to say that you didn't need the assessment in order to access these services, and so that was one barrier removed, but it did mean that individuals who were in Medicaid managed care and didn't qualify for HARP couldn't access these services in the event of a crisis. So we have opened that up. These services are going to be transitioning, like I said, to full Medicaid managed care. The crisis residences will be licensed by OMH to ensure high quality services, and just as a site-based setting, we thought that was important. And the transition will allow for a broader funding stream because it's going to allow more members to access the services. We do have a mailbox that we can provide for you all if you have questions about the crisis respite transition, because that actually doesn't fall under our bureau. So I wouldn't be able to answer many more specifics than what I've just shared with you. Next slide. So how will this transition to core decrease those barriers and improve access to services? I said earlier that that was our primary goal, to increase access to services, to make sure that any HARP member who wants community psychiatric support and treatment, psychosocial rehabilitation, family support and training, or peer support can access it. So there's a few different things that this transition will do. Number one, I've been telling everyone who will hear me out that the goal is a no wrong door access to services. So referrals do not have to come from a specific place. If you are a core services provider, you don't need paperwork from the care manager or from the recovery coordinator in order to start that intake process. Referrals could come from any number of places, a clinician. It could come right from the HARP or the MCO. It could come from a discharge planner at a hospital. And certainly we could see members self-referring or family referrals. I do see a question in the chat box. I'm sorry, I'm having trouble keeping up with all of the questions at the same time, but CORE very quickly stands for Community-Oriented Recovery and Empowerment Services. And I believe these slides will be made available for anyone who's trying to take notes. So no wrong door access. The independent assessment or the New York State eligibility assessment will no longer be required to determine eligibility. So that assessment, which was supposed to take, I believe, under an hour, can actually take much longer for some individuals. And it was just one more hoop to jump through before accessing the services. So we have been able to remove that once we switch to CORE. The services will be driven by individualized service plans that are developed between the individual and their provider. And what that means is right now the services are largely driven by a plan of care, and the goal is identified by a care manager or a recovery coordinator and then passed down to the BHCBS provider. And under CORE, these services will be negotiated directly between the individual and the provider. They will be engaged in person-centered planning. The CORE provider will help the person to elicit that goal, and then they'll develop the frequency, scope, and duration based on that person-centered planning process. So you'll no longer be dependent on a document coming from a care manager in order to get these services up and running for the individual. And hopefully that makes the ISP more meaningful to the person when that is the primary driver for the services. The services will also no longer be restricted based on where an individual lives. So many of us are familiar with the HCBS final rule, sometimes called the settings rule. And this meant that individuals who resided in community residences or in adult homes or other institutional settings could not access these services. And that excluded a number of HARP members who were interested in things like peer support. So by getting out from under HCBS and doing a rehab demonstration, we're able to open up these services to any HARP member who's found eligible. And so the eligibility will be based on HARP membership and then a recommendation by a licensed professional. Next slide, Liam. So what does this look like? I think of things very visually. So the answer, what does it look like? What's the workflow going to look like? We're still working on it. We would love your input and your feedback. Here's just an example of how I see it happening. So it starts with that no wrong door referral process. So like I said, it could be a care coordinator, it could be an MCO, it could be the individual themselves. They get to the core services provider, no wrong door, and then the core services provider works directly with the HARP throughout intake and throughout service delivery to make sure that the services are coordinated and that the member is having their needs met. So if you look at this, it's actually much, much simpler than the current workflow, which we honestly have trouble fitting onto one slide. The font gets even tinier than this if we try. But when I say we're still working on it, I mean that, and we are very much open to working with stakeholders and hearing how you think this could work. We want to make sure that it stays simple. We don't want to put more hoops in it than there needs to be. And when you think about other rehab services like PROS, there isn't something you would call the workflow. Every agency has an intake process, and that's okay, that's appropriate, and that's more of what we would like to see in CORE, is agencies work to develop effective policies and procedures that get members engaged in services as quickly as possible and that high quality person-centered services are delivered. And so just like PROS, you're going to work closely with that managed care organization. If they have a care manager, you'll want to make sure that you're in communication with the care manager, but ultimately the individual receiving services is really just dependent on them getting to the provider and being willing to engage in the services. Okay, next slide. And I would be remiss if I didn't talk a little bit about the impact of COVID-19 on the current BHCBS services. We saw a massive transition of these services. As you all know, they were completely delivered face-to-face and in person prior to the pandemic. Most of the services were one-on-one. We saw very few groups happening through psychosocial rehabilitation. And in March, we had to pivot just like pros and just like the rest of the system. In doing so, we had a lot of lessons learned on mobile rehabilitation and what that looks like. So the first thing I'll say is that demand for the services has continued. And even with all of those current barriers, even with the independent assessment and needing the comprehensive plan of care and the LOSD process, which is the level of service determination process, even with all of those barriers, people are still raising their hand and saying, I want these services, I want peer support, I want rehab services, I want clinical counseling and therapy at home. And so the referrals have actually increased in many places. Providers are conducting their intakes both in person right now in some cases, obviously with appropriate social distancing, and through telehealth. They are able to conduct the intakes as well through audiovisual and telephone, I would just add. So HEART members have reported pretty high satisfaction with these services. We've received a number of surveys from providers who have done satisfaction surveys for their clients, and they're showing that people are very happy with the services. In some cases, they're happier with the services now than they were before, and in other cases, they're just as happy, and it's actually a very small minority who want to go back completely to only in person. Many people are very interested in a hybrid model for BHH, CBS, or CORE as well. Members are reporting feeling connected to their service providers during this time of crisis, and they've really benefited from that increased flexibility and creativity. We're hearing that providers are doing really cool and innovative things to keep members engaged in services. Particularly earlier on in the pandemic, we had a lot of providers who were delivering supplies, they were delivering wellness self-management worksheets to people and wrap plans to people, leaving them in mailboxes. We had situations where providers were sitting out in their car on the telephone with the person who was standing in their window just so that they could see each other and feel some level of connection. And we just thought that was wonderful that providers were doing what it took to keep people engaged. We really do believe that the supportive services are well suited to telehealth. And we're hearing anecdotally from providers that they really do think this was a key role in decreasing hospitalization and emergency room use early on in the crisis. There will obviously be a lot more data to look at for that, but providers can tell us about individual cases where someone would have normally gone to the emergency room or been hospitalized, and because they were able to talk to their peer for 15, 20 minutes a day, sometimes much longer than that, they felt that they had the support that they needed and the connection that they needed, and they were able to be safely maintained in their homes, thereby reducing demand on the hospitals and the healthcare systems, and also keeping themselves safe by reducing the risk of exposure. So that was a really wonderful benefit that we found through telehealth. Next slide. I think at this point I'm going to turn it back over to Nicole, and I've seen so many questions in the chat, so I'm going to start reading just for myself so I can see where you're all at.
Yeah, I agree. A lot of good discussion in the chat. And so this is really our opportunity. We have till 4 o'clock, I believe. And so that leaves us a little less than a half hour to really, get your feedback, clarify and answer some questions. A couple of the notes I saw coming through the chat, just to kind of do a quick little step back on the transition of HCBS. So today, Adult Behavioral Health Home and Community-Based Services, or HCBS, remains as it is. So that's that transition that we talked to you about is a process that we are in the middle of with CMS as we speak. As I mentioned briefly earlier, we're in the public comment period, the federal public comment period, until October 11th. With CMS, and so that allows folks to provide their thoughts and feedback about this proposed change. So we will need to get CMS approval before going through with it. So what we outlined to you today is really what our thinking is, what we hope to see moving forward, with the emphasis on, really decreasing the barriers to access, improving the quality of services by really enhancing the workforce through evidence-based training, so that we can really focus on things like best practices in employment supports, for example, or psychiatric rehabilitation, which is a concept, although we support it, we talk about it so much, it's not necessarily widely practiced. So this is really an opportunity for us to think about how to build up a workforce to best support individuals in that way. So the services, the good news is those services still exist. Home and community-based services, peer support services are a part of that, family support services, psychosocial rehab, and some of the ones you heard Katie talk about still exist today. They still require a level of service determination and that independent assessment to access them. That's still happening. And when we get CMS approval, we'll have a bit of a transition time for providers and for managed care plans, and then we will be able to make an announcement about when the shift will occur. So in the meantime, we truly do have an opportunity here to get your feedback about not only what access should look like, but the way in which services are accessed and received. What is working, what should we pay attention to relative to, telehealth and some of the examples Katie shared with you and Liam went over. So I hope that answers just a couple of them, and I really apologize. We are so used to using acronyms, and there's a lot of questions about, the acronym soup that we've referenced here. So, I hope we covered that. And so essentially, CORE is the new acronym for what will be the new approved version of HCBS. And so that with that, Harvey, I'll kind of, let me know what your thoughts are on the discussion. I can start to go through the chat box and, myself and my team can try to address some of the comments and questions, unless you wanted to open it up and have people take themselves off mute. Really, whatever your preference, we're good to roll with it.
I don't know if is Eileen with us to do that? We generally don't take it off because it gets
Okay.
But
Yeah.
I just want to say that the level of dedication, that you have suffered through this as we have, about what hasn't worked and what people haven't been able to get. You're right on the values, you're right on the services, and this is so encouraging for so many people. I really it's going to help people's lives, and it's going to grow peer support in a way that long should be happening. So I just want to also put in a plug for self-directed care, which at one point was considered maybe one of the services. I don't know what, you probably can't say anything now, and I'm not sure it's even feasible, but I just want to keep it in front of everybody because it is, to me, the most transformational service. It would be a great fit with these things as well. But after that, I think if you want to go ahead with the chat box, I don't think we have a better way to do it.
Okay.
And let me just ask you, if I take off my camera, is that cat there or do I disappear?
Right now I can see you with the NYAPRS logo, and now I see the cat, which I think many of us are very happy to see the cat. So no worries, Harvey.
All right, I'll leave the cat on then.
It's a welcoming face. Okay, so just kind of scrolling back to the top as we've been going, there's a couple comments about clubhouses running different types of training. I did address, I think back where someone mentioned that many folks don't have access to telehealth service tools or technology. And so that is, absolutely why we need to account for that when we begin to think about and envision a new system that really offers choice and honors preference. And that's exactly what we're trying to do, both with PROS and what will be the new version of HCBS. Okay, some comments about, this is what peer bridging is about, hands-on learning. So some of the values and components that we discussed within the presentation, and are some of the core components of peer support as well. And, peer support is one of the HCBS services now. It's one of the services we'll be moving forward with in the future. It's a part of our PROS program. So yeah, it makes sense that would be a big piece here. We do not have PROS, just a couple of comments. There was some comments about address the deficits and social determinants of health. I'm not sure if that's a question, but I will say that a couple years ago, I did a presentation about how rehab and recovery services can support social determinants of health and the challenges related to those. And so, one example, and I hope this gets to your comment, Andy, but if not, feel free to add an additional note. So this is one of the big values for us around rehab and recovery services, that because it goes beyond just simply managing someone's symptoms. Okay, we're going to make sure you get medication for that symptom. We're going to, make sure you can see a clinician, a licensed therapist, and engage in some psychotherapy maybe. This is really about, and then what? And you want to reconnect with your kids that you haven't talked to in years. And you want to go back to school, and you want to go back to work. And this is a perspective ingrained in these models that doesn't say, the clinician will tell you when you're ready to do those things. I will tell you as the clinical expert what your path will be. These services are all about you telling the provider what you want. The participant is in the driver's seat. So that when you think about things like social determinants and how something like poverty has such a major impact on somebody's mental health, Liam is always saying employment is recovery, right? So there's a lot of research and a lot of background that supports this concept of if someone says they want to work, help them get back to work. You don't tell that person when they're ready. You just help them to get to that place. And in turn, that can start to address that vicious cycle of, living in poverty because you're unemployed continues to expose you to more challenging and adverse situations. The daily struggle of that reality. When maybe pursuing employment not only is better because you have some sense of purpose or something to do during the day, but also you start to be able to maybe not have to live in such a way where you're worried about paying rent every day or paying for groceries. So I think these services play an integral role in addressing some of those pieces. And as you can tell, I'm passionate about that subject, so sorry to maybe go further than you were looking for. Okay. There's a question that says, what should be the qualifications of the supervisor? Should they carry a CRPA certification as well as the peer? So one, and I don't know if that was to the state, it looks like it's to all panelists, so maybe just opening up that as a discussion point. I think one of the things that we're trying to do, that's a really valuable certification, especially as it pertains to the services that we're discussing today. So in depending on which program you're talking about, there are different qualifications for each service. And so one of the lessons learned from the HCBS transition would be, just being mindful of who the supervisor is and that they have the right tools and training to best support the staff that are actually providing the service. So that's the advantage of sort of starting with something and being able to make some changes, because we've received a lot of good feedback about that and what the appropriate mentoring and coaching support looks like, how to help maintain the integrity of a peer support service so that it's not clinical, because that's not the point of it. And so if a clinical person is supervising a peer, someone providing peer support, how do we make sure that that person is supporting that work? Psychosocial rehabilitation, PSR, yes, thank you. Okay, dual as in substance use and mental health. So I think they're dual eligible refers to folks that have Medicaid. So okay, so somebody did make a note that dual eligible folks are not eligible for HARP or core services. So that is true if, and people do use the word dual in different ways. So somebody who has both Medicare and Medicaid would not be eligible for Medicaid managed care right now, although the state is looking at that. So they in turn would not be HARP enrolled, and only HARP enrollees currently can access HCBS. I hope that answered that question. And Harvey, let me know if you see something that I'm missing here. I'm just going through. Okay, when will the switch from HARP to core happen? And including the elimination of the eligibility assessment. Everybody's, excited about that. That's, that's a process for people that is not friendly. And also it's additional workload for a care manager. And those are exactly some of the key steps we want to remove so that the access is easier and people are able to more directly refer. So that would not happen until after we receive CMS approval. And then we've asked for about a 3-month transition period, and that way we can make sure that all the providers understand what this transition is and what that will look like for them. And then, of course, the people who are receiving services, make sure that there's a continuity of care process. So the state will absolutely make an announcement in advance, letting everybody know that CMS has approved. We're very hopeful, and it's looking very good. When someone was receiving HCBS, they couldn't receive CCBH services at the same time with core services. Just seeing where, trying to hear the question in there. So what I'll say is when we introduce the new core services, like we have today, where there's sort of, we have an actual chart that will tell you when someone's eligible for which service. We'll have that for the new array of core services as well. And that will spell out where there might be duplicate services versus, where somebody could already receive that service in a CCBHC, for example. So we'll have much more information on that as we roll it out. Okay, how does switching to core impact Medicaid reimbursement? I'm thinking about what that might mean. So how does switching from HCBS to core impact Medicaid? I'm guessing that you mean, Laura, on behalf of the provider. And although I'm not completely sure where you're going with that, I'm going to try. So the rate structure will remain almost exactly the same. And the process to which the provider gets paid to provide the service, hopefully will look a lot easier in the way of the work the provider does with the managed care organization. And that would be all a part of what we're trying to work through moving forward, with the theme that we don't want to have to get all this authorization up front. We'd like people to get right into the service, start receiving the service, and have the service provider work with the managed care plan on the other end. So I hope that answered it. And my team too, if I'm missing other things, you guys let me know. Oh, okay.
There's a couple of questions about Access VR and core services and whether you can receive both or if you have to choose.
Yeah. Did you want to grab that one, Katie, or did you just?
I can, yep.
Go ahead.
So there shouldn't be a duplication between core and Access VR services. In fact, we actually see like a really nice synergy between the two. We think that there are many opportunities when an individual could benefit from receiving, say, for example, psychosocial rehabilitation to provide rehab counseling so that they will be more successful in an educational environment. and then they may receive things like transportation, tuition assistance, and advocacy support for accommodations through Access VR. Similarly with employment, someone might receive job placement through Access VR, and then they might receive psychosocial rehabilitation to work through behavioral health barriers on the job. So we actually see that the services can complement each other really well, and there shouldn't be a circumstance where an individual needs to choose. It was a little different under BHH-CBS. There were more restrictions, and that's because we had explicit vocational services that did in some ways overlap with Access VR. So this should eliminate that issue as well.
Thanks, Katie. There's some good comments, advocacy points on self-directed care, which Harvey also responded to. Thank you, Harvey.
You're welcome.
And you are absolutely right. They are still in the pilot phase. And Don, I believe some of Don's team is on the phone today, has presented in detail with the providers about that. And so I think there's a lot of good sharing of information in the chat if folks are looking for more detail on that. Karina loves the quote, empathy, employment is recovery. I think that's Liam's quote. At least I give him credit for it. Liam, will you take the credit?
I'll say it again, employment equals recovery. Karina knows we've done a lot of work together on this very topic for a long time. And thank you, Karina, for keeping up the fight.
You know, I have a question or a comment.
Sure.
I worked for 10 years in a club, social club in Albany. And I supported the move to pros, although I recognized there were things, really important things that were lost, that were more informal and family-like and networking. We shouldn't want a segregated environment that's forever, but there was some extra value to that. And I see people chatting about, so when you look at a pros without, I mean, is there an opportunity? You know, Medicaid billing has been very restrictive around allowing more informal sort of gatherings and activities and things like that. I hope I'm being clear. I guess my question is, do these changes and the flexibility you're pursuing offer the possibility of some sort of club-like activities which aren't tied strictly to 15 minutes and you're working on this particular goal and to get a reimbursement? Does that make sense?
It does. Thank you, Harvey. And I think that sums up a lot of the comments I was seeing. So, you know, it is true that when you're dealing with Medicaid, you're talking about medically necessary services, and, you know, you have to justify how it's medically necessary. And so that's why we're excited about rehab in general, because we have a lot more leeway in the rehabilitative, you know, authority in our state plan. You know, we're even thinking about moving our clinic, which is a large service throughout the mental health system. It hits the most number of folks, frankly, into the rehabilitation state plan amendment, so that there are more allowances for flexibility. But at the end of the day, you know, we have to sort of work within the constraints of Medicaid if it's Medicaid that is paying for the service, right? And Medicaid will pay for psychiatric rehabilitation. And there are many different aspects of that. So to the extent that we can track it back to, you know, how, you know, skill building and those supportive services are benefiting the individual, and they're addressing the barriers that maybe the mental health challenges have presented for them. There's a way, you just have to make that argument towards a medical necessity for the service if you want to use Medicaid, but there are other types of funding also available. And so, you know, we want to think creatively about the state aid funding that's out there. You know, are we using that most efficiently? And so if there are pieces that Medicaid won't pay for, how should we more wisely utilize state aid to support that? Because, and I appreciate a lot of the comments in the chat about you know, clubhouses and that environment, because if there's a value to that, that's helpful for us to hear too. You know, maybe keeping that site, you know, or making sure we have some sort of site so people can access that environment in a more informal way, as you said. If that's a value, then I think we need to build that in to the system as we redesign good parts of it.
And now, Nicole, if we can avoid these cuts to state aid, that would be good too, right?
Oh, yeah, you
I
know
know
it.
that's not, I'm not trying to walk you there. That's not your part
No,
of the street. But
I wish.
I know there are people on the phone that when they hear state aid, they know it's being cut. So as an advocate, we just want to assure you we're working on that. But it is vulnerable right now.
Yeah, no, I think you're right, and that's why we have to look at what's out there, what it's being utilized for, and so make the best of a very difficult situation. And so if we're cutting things, and we're looking at things like state aid that is a $1 amount and supports 4 people, and the same dollar amount is supporting 24 people. So those are things like, hey, how can we look at that differently? Instead of just cuts, how do we make better use of it? And what are values in the system that we can make sure we need to support and get behind when we're in these very challenging times?
Sure. Thank you.
Nicole, do you want one more question about the transition to core that I saw?
Sure.
I know we're running low on time, but people are asking about, number one, the time frame for the transition, and number two, just confirming the understanding that the plan of care and the LOSD go away. And I can answer those, or you can if you want.
No, go ahead. Thank you.
So as far as the time frame, we don't have a date as of right now, but what we have told providers is that we're looking to implement it about 90 days, or at least 90 days after we get CMS approval. So Nicole mentioned earlier that we're in public comment at the federal level right now. And so we don't have that approval just yet, although CMS is aware of and supportive of our application thus far. So when we get approval, we will have at least 90 days to make that transition. And certainly you'll receive a lot of guidance and support and training from us. And we'll work with our training partners to make sure that we have a number of webinars and resources available. So that's the transition piece. The LOSD, which is the level of service determination, which gets you approval through the MCO to do the intake, that piece should go away. It'll look more like a notification to the MCO that, hey, we have someone here who's going to do an intake, and they can do a quick check to see like, oh no, this person is in pros and maybe therefore can't get psychosocial rehabilitation, or there would be very few limiting factors, but that notification to the MCO gives them an opportunity to let you know if there's going to be any issue. And the plan of care for those members who are still health home enrolled is still going to be critical, but the core services provider won't be dependent on that documentation. So just like if you're a PROS program and someone has a health home care manager, you're not sitting on your hands waiting to get the plan of care before you begin services. It'll be the same way for core. And just like for clinic and housing, or any number of our other Medicaid funded services, while the plan of care is important, other service providers are not dependent on it for reimbursement or for coordination purposes. So that's what will happen to the plan of care.
Thanks,
and to John's question, yes, when I talk about a care manager, I'm talking about the health home care manager.
Thanks so much.
Okay, so I would be remiss if I didn't recognize David Bucciafero, who's in the crowd there somewhere, for his landmark work on PROS, and also Kelly Loletta from Community Care, whose company paid a lot of the contribution that made us able to give this for free to most of you. So I didn't want to say that. So thank you two very much. It gives us hope, I think, for the future, and knowing you're working on it and care like you do, and we can tear away a lot of the barriers and complexity to get to recovery is just really historic. I mean, we didn't make it the first time because of that design was so complicated. This looks like it's going to be a winner. So thanks for all your work and all the people at OMH over there too.
Thank you, Harvey, for your ongoing advocacy and, you know, continuing to give us really important feedback that's really going to help drive all this. So thank you, everybody, for your time and really thoughtful comments as well.
Thank you. Have a good afternoon.
Yeah.
Bye, Liam. I wish we could have seen your tie. Now, folks, I don't know, I should know this, but I think if you stay on, you'll get to the closing comments that I'm a part of, but let's see if that happens.
Cool.
I don't know if one of our staff is here. Am I right about that?
Yeah.
Eileen? They stick around, right?
Yes. Yep. We should have other people joining us. They're joining us now.
Okay, thank you. Okay. Stick around a little, Mitch, if you want to hear the closing comments, but we can take it.